network. Thank you. Webinar series. So I'm your host today, Michelle Skelton. I'm based at UCT. I'm also a PI on H3 Africa and DSI Africa consortium. And I'm here today to welcome you. So thanks so much for joining us. Just a little bit of background about the African Pharmacogenomics Network. It really aims to build capacity for pharmacogenomics research and implementation on the continent. It was launched 6th of September 2018 at the University of Cape Town, and this network is also affiliated with the African Society of Human Genetics. Many of you may be members of that as well. So there are several pillars to this network, wanting to build the pharmacogenomics community, capacity building through fellowships and training, and also events like this, and of course, perhaps with an increased membership, annual face-to-face meeting. I suppose that is also something that we would be working on as well. So we are really honored to have a speaker with us today, Professor Mohamed Nagy. So welcome to you, and thanks so much for availing yourselves to this network and to our community. So just a bit of background on our speaker. So Professor Mohamed is the head of Personalized Medication Management Unit at the University, at the Children's Cancer Hospital, 57357. He earned his master's degree in biotechnology from the American University of Florida. He studied how specific genetic polymorphisms increase the risk of thrombosis in Egyptian patients with acute and lymphocytic leukemia. Mohamed is also considered one of the experts in clinical pharmacogenetics and nutrigenomics in the Middle East and Africa. He's dedicated his genetic knowledge not only to patients and around disease, but also allowing healthy individuals to find the best sports and nutrition routine tailored to the unique individual genetic makeup to achieve the best health outcomes. Mohamed is the founder of the Pharmacogenomics Access and Reimbursement Coalition and the founder of Standardizing Laboratory Practices in Pharmacogenomics. That's Stripe. So currently he's leading the Pharmacogenomics Research Developing Countries Committee for the area of the Middle East and Africa, and is also head of the IVPN-Personalized Medicine Listserv. So quite accomplished, and it was an honor for us to have you here. So just a bit of housekeeping before we allow our speaker to go ahead and inform us about his talk and his research. Just some housekeeping. So this session is being recorded, as you would have seen, and when we open the session for Q&A, please post your questions in the chat. If you would like to speak, please raise your hand so that we can all benefit from this webinar. So thank you so much, and I'll hand over to our speaker today.
Thank you so much, Michelle. Thanks for the APN for invitation today. So my name is Mohamed Nagy. I'm a clinical pharmacist, and I am the director of the pharmacy at the Children's Cancer Hospital, Egypt, 57357. So, and this hospital is totally for free, depending only on donations, and it's NGO. We are working with pediatric oncology only, and we already have a unit for personalized medication management, and we already implemented pharmacogenetics here since 2018. So, what I will talk about today is generally about personalized medicine, and especially some examples in oncology. First, as I told you, I'm a pharmacist. And if you never heard before about personalized medicine, so personalized medicine is a booming field in the healthcare right now. And actually, it's their personalization idea there in the market since a very long time ago. As you can see, this is Nutella jars, where long time ago, I think in 1990s, the company itself started to have the Nutella with names on it. So in order to make a personalized label for the customer. Also, I went to the website for Coca-Cola, and I found that I can add my name and I can send the bottles back to my home, which is again a way of personalization. you know M&M, so it's a type of chocolate. And actually, I already took this picture with my own phone when I was in Las Vegas in 2019. There's a very big center for M&M there, and you can imagine how we can personalize M&M. So you can add your photo on it, and you can order the amount that you need with your photo on it. The last example is Revive, Revolve, sorry. So Revolve is a website for ladies where you can order a certain dress or something that you like from it. And the personalization here is when you go to the cursor in order to close the X cursor, you will find an automatic personalized discount that appear for what you were looking for. So again, this is a way of personalization. For sure, and then Spotify and all the applications that's used and Netflix, all the applications that's used daily. So also it make a personalization where after you listen to a certain song or see a certain movie, you will find next day or even the same day, you will find a suggested playlist according to your way or your type. So all of this is personalization. And now you can understand that our life is filled with hyper personalization. And also you understand that personalized medicine in healthcare is very late. So personalization is everywhere. So Hippocrates said long time ago, it's more important to know what sort of person has a disease than to know what sort of a disease a person has. Where that's why I always say we started personalized medicine late. And what's personalized medicine? So if we go to definition, so personalized medicine is tailoring of medical treatment to the individual characteristic of each patient. And there are different flavors of personalized medicine where there's a personalized medicine, precision medicine, targeted therapy, individualized medicine, and stratified medicine. All of this can be under the umbrella of personalized medicine. Also, there's something called B4 medicine, where it's P for predict, prevent, personalize, and participate. So we can understand how personalized medicine can help in the prediction of the certain disease, can help in the prevention of a certain side effect, can help in personalization of a certain dose, but how personalized medicine can help as a participate. Just think about it. So as a participation part means that the patient himself can participate in the decision of the doctor. For example, when the patient go to the doctor and the doctor tell him, okay, we will do a genetic test. You have a certain mutation in this gene, and if you took the full dose, you will have a side effect. At that time, it's the decision, or it's a decision of both the physician and the patient to take together. So where the patient now can participate in the decision. And this is in cancer. So on the left, you will find the traditional way of medicine, which is using radiation, chemotherapy, and surgery. And on the right, you find some personalized medicine approaches that can be used now in combination with the traditional way, which is genetics, immunotherapy, targeted therapy, and so on. But why personalized medicine is important? Maybe somebody tell me, I have my own profession. I work as a community pharmacist. I work as attending physician, and I don't need the personalized medicine. Everything now is good for me. I like numbers, so I can show you some numbers. So personalized medicine are top 20 medications of FDA approvals for 7 years in a row. So you can find that more than 20% of each year approved medication by FDA, more than 25% even, is under the category of personalized medicine. And also, those medications, more than 47% of them is cancer. But what are the different applications of personalized medicine, especially in cancer? The first thing we can start from the left. So the first thing is risk assessment, where here is the risk assessment. We can answer the question is, am I at increased risk of cancer? Another one is the diagnosis, which can answer the question of, do I have cancer and what type of cancer do I have? Then the prognosis, where what is the expected course of my cancer? According to prognosis, for sure, the treatment is totally different. Then the prediction, which is answering the question of will my cancer respond to the medication? Then the pharmacokinetics, which will answer, should I receive normal or lower dose or none at all? Monitoring and the answer of the question, how's my cancer responding to this treatment? And has my cancer come back for monitoring effects? So let's have a real case. You know for sure this is Angelina Jolie. She is a very famous actor. In 2013, Angelina Jolie has wrote an article in the New York Times called My Medical Choice. And the article had this story where Angelina Jolie lost her mother with an ovarian cancer and the breast cancer for her grandmother and her aunt, where she detailed her decision to undergo testing for BRCA1, known to dramatically increase women's chance for developing breast cancer. And when she went to her doctor and he did the BRCA1, he found that yes, she has a mutation. And at that time, he told her, you have to do a double mastectomy in order to prevent having breast cancer. She already did that. And when she did that and announced that, that caused a spike in the number of genetic testing done worldwide for the BRCA. But for sure, that doesn't mean that there are a lot of mastectomies done, because this mutation is very rare. But the good thing is, this is one of the ways where the awareness increased about the importance of genetics in prediction of disease. So let's talk now about another definition, which is the pharmacogenetics. So what is the difference between the pharmacogenetics and pharmacogenomics? So you can find that sometimes I can tell you pharmacogenetics. So while I am writing a paper, I can write it as a pharmacogenomics. So yes, there are two different definitions, but the main change is how the variation in one single gene or in multiple genes will affect the response to a certain drug. So the response here is defined either by efficacy or side effect. But I can tell you that the post words pharmacogenetic and pharmacogenomics can be found used interchangeably. Okay, and here on the left you can find the normal one without personalized medicine, where if you give us the same therapy, let's say today we have a headache, all of us will take paracetamol. But the problem is, when all of us will take paracetamol, we'll find the larger number of us will have an effect, a small group will have no effect, and the smaller group will have a side effect. But if we use the personalized medicine, everyone will be happy because we will know the combination, we will change the medication itself, we even will use a dose modification. And I can answer a question like this when somebody come again. Okay, now I understand that's very important to understand personalized medicine, but what is the rate of prescribing pharmacogenetic high-risk drugs? Is it really there? Is it really in my hospital or in my institute? So I can tell you that this is a paper published in Nature in 2015, and it was written that around 7% of the whole medication approved by FDA is considered high risk medication for pharmacogenetics. But you can find that from the other one on the right, other pie chart, that those 7% are used, which we call actionable genetics, are used dramatically around 20% of the prescriptions in the USA. And this study was done on 4 billion prescriptions in the US. So you can imagine that around 20% of the medications prescribed in those 4 billion prescriptions have actionable genetics, which means if you did a pharmacogenetic testing, you will use the genetic testing for a dose modification or something like this. And it's not only about the percent, but only depend on the rate of use, which means that if I'm working in a cardiology hospital, you will tell me, okay, those are the percentage of medications available approved by FDA that to have a pharmacogenetic biomarker there in the pamphlet or the monograph. So I will work only with cancer because cancer is 32% out of those medications. I will say no. It depends on the specialty of your hospital. So if your hospital is cardiology only, and I can say here cardiology is 5% only, still it's very important to implement pharmacogenetics at your hospital. Why? Because although maybe 2 or 3 medications is used there in your hospital, like clopidogrel, like warfarin, like atorvastatin, but the rate of use of those medication at your hospital is very high. The number of patients using those medication at your hospital is very high. So it's not only about the number of medications related to actionable genetics at your hospital, but it depends on the rate of use of those medications. So I can show you something published in 2013, although it's old, but one of the most important publications published in the field. So it was mentioning that it was done in St. Jude from 2011 to until 2013 on 1,000 patients. They genotyped their patients, and they found that around 78% of those patients have at least one high-risk genotype. And as I told you, I will give you examples. As you can see, I like stories. So I like to tell stories because we always remember stories when it's related to what we are talking about. So when we talk about the genetics of cancer or pharmacogenetics of cancer, so there are 2 parts that we can talk about, either the germline or the somatic. Today we will talk about germline. And I will focus on colorectal cancer, okay? Because colorectal cancer, as you can see from here, it is the third, okay, the third type of cancer that happens either in male or female. And by the way, my father died with colorectal cancer. So I will talk about 2 main medications that already have a guidelines published by the CPIC, which is the Clinical Pharmacogenetics Implementation Consortium, and the Dutch guidelines, which are very, very important in the protocol of treatment of colorectal cancer and other type of cancer. And also, as I told you, have a guidelines. So fluorouracil or 5-FU or 5-fluorouracil, those are the names, is mainly more than 80% converted to dihydropyrimidine dehydrogenase, which is called a gene called DBYD, release a certain enzyme. It's called either DBYD or DBD, okay, to an inactive form. So the role of this enzyme, which is DBD or DBYD, is to convert the 5-FU chemotherapy into an inactive form. So, and those medications, this medication mainly, this enzyme, mainly is present in the liver, but also present in the other places in the body. A lower metabolic activity of DBD led to increased intracellular concentration of 5-FU-MB, which is the active form of the metabolite. What does that mean? So normally when you take 100% of the medication, let's say the doctor prescribed 10 milligrams, okay? It's well known that 80% of this 10 milligrams will be converted into inactive form. This is the normal, and only the body needs the other 20. I'm talking now about the 5-FU. What if we are having a problem in our body in this enzyme, which is the DBD? So that means that the 100% will not convert it into 80% inactive and 20% active. No, maybe it will be 50-50 or be 100% active. This will cause a huge side effect for the patient. And these side effects can be neutropenia, mucositis, neurotoxicity, and hand and foot syndrome. On the other hand, how this takes place, as I can show you here, from here, the 5-FU is converted into inactive form from 80 to 90%. Only the cytotoxic effect from 1 to 5% of those medication gives a cytotoxic effect. This is the normal. But in case of we have a problem in the DBYD, the inactive metabolite decrease, then the active metabolite increase and lead to not only killing the cancer cell, but also cause huge side effect for the patient himself. Also, it's very important to understand how this takes place on the molecular level. So normally, you know, when you have a certain gene, it's an exon and intron and so on. So as you can see from here, we have exon 13, exon 14, exon 15, and we have introns in between. So if we have a mutation here, during the splicing, there's a process called the splicing that takes place in order to have exons together. So during the splicing, this is the normal to have exons 13, 14, 15 together. But if there's no, if there is a mutation here in this nucleotide, if this nucleotide is not G and becomes A, so the exon 14 will be spliced itself, and you will have exon 13 and 15 only together. Here, the mutation will take place, and the patient will have the side effect. This is how it takes place on the molecular level. And with the pharmacogenetics terminology, you will understand that if you find your patient, if you have a report done for your patient for pharmacogenetics, if the patient is a star 2 or star 2A or star 13, that means that your patient has a no function allele, which is a very dangerous for the patient. If you give him the full dose, you have to modify the dose. And how you can modify it, this depends on the guidelines, okay? And take care, the guidelines are very, very dynamic. So you have always to be updated. But somebody can ask me, is this really severe? Because I give 5-FU for all my patients and I never see a problem. Maybe you don't see a problem because you don't know that this medication may cause a problem. Okay, let me show you something. So this is the side effect from the 5-FU. And it's not from the intravenous systematic one. It is from the topical 5-FU. There is an ointment for 5-FU for treatment of certain type of skin cancer. So you can imagine that the ointment can do this, how the IV can do. There are a lot of cases reported for the life-threatening toxicity due to the DBYD deficiency. Those are the case, a lot of cases. Also, especially with the topical 5-FU, with the ointment. So what about the IV? So you can imagine that your patient may die because of a side effect, and you are thinking about he is dying because of cancer. And this is how the pathway is complicated, and this is the different types of the fluorouracil products like 5-FU, Tiga4, and the capecitabine, and this is the whole pathway. There's a guideline published in 2013 by the CPEC and another update done in 2017. So for now, we finished the first example about 5-FU, which is a very important drug with a very severe side effect. The second example, which will be about irinotecan, which is also very important in a lot of type of cancer, but especially it's important in colorectal cancer. So irinotecan, this is a pathway, and again, it's a complicated pathway. Okay, and today we'll talk about a certain gene that already have a guideline published called the UGT1A1. So the irinotecan itself is an inactive form activated by a gene or enzyme called CE, carboxylesterase, into as an active form which is called SN38. This is the active form of irinotecan. So we need this gene or this enzyme to be activated. Then it goes to the liver to be inactivated, then go to excreted by the bile. So UGT1A1 is responsible for deactivation of the active form and excrete the lead to the excretion of the rest of the medication. That's not important. But I need you to think about it. What if you have a problem here with this gene, UGT1A1, which is responsible of deactivation? Again, it will be the same problem of the DBYD. The amount of the active form will be more than normal, which causes a lot of side effects, not only anti-tumor activity, but also a lot of side effects for the patient. And how this happen on the molecular level? Before the gene itself in the human body, there's something called a promoter. Okay, so this is the area before each gene. So normally in your body, if you don't have a mutation, there's something called a tandem repeats, where there are certain repeats of nucleotide. Here in the promoter, it's a TA. So TA is repeated 6 times. This is the normal. When you have a TA repeated 6 times in your promoter of this gene, which is UGT1A1, this is the normal. But if you have a 7 times, just a TA extra, 1 TA extra, you will have a big problem, which may lead to a huge side effect from irinotecan. This is a guideline algorithm published by the French guidelines. And again, it not only depends on the genotype, but also depends on the dose itself. So you have a multiple layer personalization. So you are giving irinotecan, you have to do the genotype. If you are giving certain dose less than 100 milligram per meter square, it's okay to start without even doing genotype. If you are giving a dose from 100 milligram per meter square to 230 milligram per meter square, at that time, you have to start thinking, okay, about genotyping. And again, it depends on the genotype. If the patient is taking the intermediate dose and he is 28, start 28, which is a high risk genotype, okay, at that time, there's a high risk for toxicity and you have to give a dose reduction with 30%. If the patient has the same mutation, but the doctor decided to increase the dose for more than 240 milligram per meter square, no dose intensification should be done. So again, it's not only depending on the genotype, it also depends on the dose that one patient will take, because this will increase the severity of the side effect. And now I need you to understand that there are a lot of current organizations responsible for pharmacogenetics guidelines, the CPIC, the Dutch, the French, the Canadian, and there are a lot other others. And also I need you to understand what I mentioned earlier, that guidelines are always dynamic. You can find the guideline for a certain drug like warfarin, for example, published the guideline in 2011, then updated in 2017, then another one 2019. So you have to be always updated. I have published with my team a paper in 2020 about how the same drug with the same genotype can have a different guidelines from two different organizations. And an example for this is a chemotherapy called mercaptopurine, mainly used for the patients of acute lymphoblastic leukemia. And when the patient do TPMT and NGT15 gene genotyping, okay, and I'm here comparing the four guidelines that I already mentioned earlier, you will find that if the patient is considered intermediate metabolizer, so 30 to 80% should be he should take 30 to 80% of normal dose according to the CPIC, but according to the Dutch, he should take 50% of the normal dose. And again, why here there is a range? Because again, it depends about the patient response. So the decision here will be the doctor decision. Here at my hospital, I did a survey and I published it about the awareness and the knowledge, because it's very important. That's why the APN is keen with doing a lot of webinars and doing a lot of trainings. So having the education at your country or at the institute about this is very, very important. So we did, before the implementation, we did an assessment, and we found that both doctor and physicians have a very low, around 40% knowledge about pharmacogenetics. But we found that pharmacists, sorry, I said both doctor and pharmacists have a low knowledge, but pharmacists in blue and doctors in red. Pharmacists have more enthusiasm about implementation of pharmacogenetics. Not that difference, but it's significant. And also a very important thing is to understand what are the challenges you are facing in the implementation process. So the first thing here was the knowledge itself, then the lack of testing and limited funding and so on. So you find this limitation in every institution, but the arrangement of the limitation itself would be different from one place to another. Then we found that we started to do a lot of courses and on-site courses with Colorado University, and then we started the implementation. So when the implementation started in 2013, the CPIC started, okay, the number of people implementing pharmacogenetics according to the CPIC were very few. Then this is an analysis done in another study where around 45, at that time, 2020, around 45 sites only were endorsed by the CPIC on their website as an implementer. More than around 34 out of the 45 is in the USA, while those are the rest of sites. Maybe there are other sites we are implementing, but they are not there on the CPIC website. Okay. And unfortunately, there are no sites there, up to my knowledge, on the CPIC website from Africa. There are not a lot. Okay, so maybe for sure there is implementation, but maybe it's not there mentioned. And always when we are talking to each other, we always say, please don't take it personally. But actually, I'm telling you that take it personally, because as you can see from the picture, we are totally different from each other. Okay, so take it personally. We are different. Every one of us need a different treatment, need a different way of diagnosis, need a different dose. I always used to use this slide since 2010 when I started to give sessions, and now it's real. Here's my sequence. Please give me a drug for a headache. Now it's really real. Implementation of pharmacogenetics is everywhere. It's increasing and it's booming. And the APN consortium is trying to increase awareness, training, and implementation in the whole Africa. So this is my team in the pharmacy here in 57257. And I would like to thank you so much. This is a QR code. You can scan it for my LinkedIn if you need to contact me or ask me about any other thing. And thank you so much, APN. Thank you, Michelle. And the floor is yours if you have questions.
Yes, thank you so much for that interesting talk. And I think we will go directly to Q&A. You can please post your questions in the chat. And while people are thinking, Mohamed, I'm just wondering, so you said the CPIC consortium has no sites in Africa yet. Okay, we have a hand up, so let's go to Khaled first.
Yes, sure.
Go ahead. Khaled, if you're trying to talk, maybe.
Okay, yes, I was finding it difficult to open my mic. Let me thank you so much, Mohamed, for the presentation. Quite a wide range of areas that you have touched. Interesting. I wanted to hear, Mohamed, can you hear me?
Yes, sure, yeah.
Yes, I wanted to hear in terms of implementation. Where are you now in terms of the area that you are working in terms of using this test really to inform therapy and dosage? Thank you.
Okay, so thank you. Actually, we started the pre-implementation process in 2016 here at my hospital, and we were live implementing in 2018 with a panel covering 10 genes, and all the genes are actionable. So we are doing this for all patients, and we are doing this preemptively. Then after doing that, it's automatically sent to Cerner, which is a hospital information system, in order to have the result there before the patient is taking medication. So for example, I know that this patient is acute lymphocytic leukemia. I know the protocol. I know he will have a 6 mercaptopurine for sure during the 3 years. He will have a voriconazole and so on. So I do the genotyping preemptively. Once the patient admitted for the first time, then I will send the results directly to the system to be stored there. Once the doctor starts to write down the voriconazole, for example, he will have an alert telling him on the system, take care, your patient CYP2C19 star 17, which is a rapid metabolizer. You have to change the dose. You have to give another medication. Take care, your patient is so and so. But if there's no high risk genotype, there's no alert will appear in order to avoid alert fatigue.
Yeah, lovely. And yeah, okay, I will come with another question after others. Thank you so much.
Thank you.
Khaled, thank you. Khaled is very excited about your work. So thanks so much. So I think, I'm not sure whose hand went up first, but we'll go with Ted and then with Deogratias after that. Thank you so much.
Yeah, thank you very much, Mohamed. I was wondering in your definition, can you clearly define personalized versus individualized versus precision medicine in terms of what actually it means from patient's point of view?
So if you started to read about personalized medicine, you will find a lot of literature. Some of them are using stratified medicine, for example, especially in the UK. Another one is using individualized medicine. Another one is using personalized medicine. For example, in 2015, I think in 2015, when Obama started to talk about a precision medicine initiative, so you can find that there's a big use of the in literature after 2015 about talking about precision medicine. So for me, all of them are under the same umbrella. Okay, some countries or some institutes are using one definition or another. Yes, there's a difference in the definition. It's a very tiny difference between the personalized and precision medicine. But actually, what we are talking about, especially in pharmacogenetics, it's all the same. Either you are saying individualized, somebody is writing a paper and they're saying tailored medicine. It's the same. They are all talking about how to modify the dose or the way of diagnosis or the way of treatment in order to fit the patient criteria.
Thanks so much.
Okay.
So we'll go to Diogratius. Please go ahead.
Okay, thank you very much, Mohamed, for a very nice piece of work and presentation. My name is Deogratius Katabaro from Tanzania, Mwanza. I'm a clinical pharmacist working with the pediatric oncology department. I was wondering if this kind of information is very important for our patient and we are not implementing it. We are not currently practicing the precision medicine in our clinic. I think some of our patients are suffering from various adverse drug reactions, and some of them might be dying simply because we don't do this. So I wanted to know what is the cost implication if we want to implement this kind of practice? And this question is followed up by, do you think is it possible to detect variants among children here in sub-Saharan Africa, particularly Tanzania, if the methods which is available, is it cheap? Is it affordable? I mean, can we get kits and do tests for our children? Thank you.
Thank you so much. So yes, this is very important, the funding itself. But I can tell you something, it can be solved by another way. So now for some companies, some pharma companies, they have what they call companion diagnostic, where they have the drug itself, which is a personalized medicine, and should be taken when certain mutation is there, like PCR-able, for example, for imatinib. But they also have the test. So what some institutes doing is having an agreement with this company, telling them, okay, I will take the medication from you. This medication is very important for my patient, but it's not important if I don't do the test. So the company covers the genetic testing for each patient before starting the chemotherapy. Okay, at that time, the agreement is done. This is one way of agreements. Okay, and this is happening here in Egypt. The company should cover, but not of my lab. So my lab, I am doing, as I told you, I'm doing the germline. Okay, for the somatic, this is happening in Egypt. To do the company agreement that they have to cover the test on their own, since I will get the drug from them. Okay, and they will not get the drug except the patient. You know that the patient will should be treated with that drug. So sometimes when you do the genetic testing, you know that this patient shouldn't be treated by that drug, should be treated with another line. Okay, so that some companies doing this. Another way is having the fund. So I think there are a lot of places to have fund right now, and again, APN is trying to help. Is for having fund for something like pharmacogenetics. It's not that expensive at all. It's much cheaper than having a side effect it's much cheaper than having for a side effect for patients, the patient die, or even it's much cheaper than having a side effect and the patient stay at the hospital going to the ICU and at the same time the length of stay increase. This is all cost. When you do a cost effectiveness study with the length of stay, with the cost of 1 day at the ICU, you will find that it's much cheaper to do the testing for all the patients than having the side effect for 3 or 4, which will cost you much expensive. It will be much expensive than even doing the test itself. A lot of studies there in the literature talking about that. I hope I answered your question.
Thank you very much.
Thank you for the question. So we'll go to Benningfield. You have your hand up. Please go ahead. Benningfield, Benningfield, you have your hand up. Are you trying to unmute?
Hello. Hi. Hello. I'm Yusra Hafani. Just thank you so much, Prof. Just I want to make sure. Yeah. Thank you so much, Prof. Mohamed Nagy, for the great talk. It's really interesting what you are presenting. My question, first of all, I want to know why did you see any outlier for those patients you are doing already the genotyping, like some resistance profile, and those the cohort, the one already working on them? And my second question, why you are using germline cells for your genotyping? You are saying you said something like that, no?
So thanks to Yusra. So there are two types of pharmacogenetics, germline and somatics. So for somatics, there are people are doing for the cancer itself. For the germline, or it's for the C2C19, C926, and all of this. So this is what I am doing in my lab. Especially it means that those modification after that. In other lab is doing the retrofit. That's what I was mentioning. So I am doing genotyping for C9, C19, C2C6, DBYD, MTHFR, and other genes, which already have a guideline there. And for resistance, Doctor, could you please clarify what do you mean by resistance? You mean the resistance for the medication itself?
Yeah, did you see like some resistance? Yeah, to because you said you did some genotyping, like the molecular profiling of your patient, and you gave them like the medication according of their genotypes. I want to know if
so in my lab I do post
like other than those mutations.
Yeah, so in my lab, the good thing is I do both in the lab clinically the therapeutic drug monitoring and the pharmacogenetics. So we can especially for something like voriconazole, therapeutic drug monitoring is recommended, and pharmacogenetics is also recommended for C19. So sometimes when you do C19 preemptively before the patient start the treatment, we can find the patient is rapid metabolizer, for example, and the recommendation is to modify the dose, or if he is at a certain age, no, you have to give an alternative. So, but sometimes the physician said, no, I prefer to give the standard dose. And when we give the standard dose and we start doing the normal therapeutic drug monitoring, we will find that the patient is 0 level. So we come back to the first guideline, so the first dose. So this is what we can see when we have a therapeutic drug monitoring available for the medication. Sometimes the medication is not recommended to do a therapeutic drug monitoring. What we found is that there are a lot of sterile leads recommended to be done, and it's zero frequency in Egyptians, although it's have a high frequency in Caucasians, and vice versa. For example, for TPMT, so in the USA, it's reported it's around from 11 to 13% in general mutation. In Egypt, it's I think it's less than 1%. Although I do more than 10 RSs. It's not only STAR3.
Okay.
So for it depends on the population.
Yeah, for the patient, the one they showed sensitivity to the drug, the 5-fluorouracil. They showed like those skin, rashes.
But for the 5-fluorouracil, doctor, is mainly used in colon cancer, and the colon cancer is not a pediatric disease. Colon cancer mainly comes to adults. I work with pediatrics. That was just an example.
Okay,
Yeah.
that's an example. Okay.
Yeah, but for the allergy in general, we don't have the same. For example, for phenytoin. So we are using phenytoin here in Egypt, IV for all patients that have seizures, especially for brain tumor patients, which is high prevalence in pediatrics. We never see 10. We never see this type of allergies that's reported. Mainly, it's an HLA correlated, and mainly it's in Asia more than in Africa.
Thank you so much.
Thank you, Doctor.
Thank you.
Thanks for those questions. So Colette posted something in the chat. I'll just read it. So he says, from his side, precision speaks to how accurately we predict something after taking into account all necessary factors, including environmental factors. Individualized speaks to focused on a particular person, more looking at underlying genetics, comorbidities, and the state of general health. And last, stratified is simply responding according to a patient's group needs, say poor metabolizers versus extensive metabolizers versus etc. Thanks for that. So I just wanted to ask Mohamed, there's a lot of questions about implementation. Folks want to know how to do that. And of course, you're in a consortium that deals with that. Maybe you can speak a bit more about that and the criteria to join that consortium. It's the CBIC. What is the criteria to join? Is it a fairly easy process? Because like folks from Tanzania, they need to have this implemented into their healthcare system. So maybe
I think what I know that being a member is not hard at all. Being a member, attending the meetings, know what's going on, know what's the guidelines, what's the next guidelines, so on. I think it's open for all the people who are interested in pharmacogenetics, but being there on the website as an implementer, you should be an implementer. You should have an real implementation at your site, and you should, and they ask for a lot of papers about that. But being a member, attending the meetings, attending the monthly meetings, know what is the news, this is open.
Yeah, so there's a question in the chat from Jenna Gratis again, from Tanzania. Is your lab, Mohamed, based in Egypt or the US? Do you perform tests for other research institutes? Which types of samples are you using for your tests?
So I use blood samples. Then I extract the DNA from the blood samples. Yes, my lab is in Egypt, not in the USA. I'm in Cairo. As I told you, my hospital is called Children Cancer Hospital Egypt 57357. It's the largest pediatric oncology hospital regarding number of patients. Okay. And I do for other institutes, yes, not a research institute, but as I told you, my lab is clinically mainly, but I join research projects, but this is away from the main clinical work. So yes, I join other institutes for research for sure.
Do you offer, sorry, I don't know if you answered, do you offer testing at your lab?
Yes. I can offer testing, yes. If somebody needs to send samples, I can offer testing for sure. We can arrange this.
And what samples do you need? Plasma?
DNA.
DNA, what do you use?
DNA.
So already extracted DNA.
Extracted DNA.
Okay, perfect. So the other thing I found quite interesting about your talk was that the model you spoke about between the pharmaceutical companies and, I'm not sure if it's between the pharmaceutical companies and you or pharmaceutical companies and government, about that they would pay for the genetic.
The pharmaceutical companies and the government. So this is done with the MOH. Yeah, it's done with the MOH. Okay. Minister of Health.
Okay, so that's a really good model to promote and to share with people that the Egyptian government is actively doing this, where you get sort of it's a great,
especially in companion diagnostics. So
it's beneficial. Yeah, it's beneficial for both. Yeah.
Yes.
So I think that's a really good model to highlight, that people can learn from and say, oh, the Egyptian government is doing this, why aren't we doing it? You know, work with pharmaceuticals to get what
it's the same companies. It's the same companies
exactly.
many works.
Exactly. Yeah.
Maybe
Okay.
because you didn't ask. So
yeah. So we 10 minutes almost to the hour. Are there any last questions for Mohamed before we make the closing remarks?
And again, if you have any questions I didn't answer, please send it on the LinkedIn. You can scan the QR code and send it on message.
So thank you. I think we're going to close the meeting now, just to thank the organizers and the African Pharmacogenomics Network, Vicky Nambawada and her team for organizing this meeting, getting the speakers into the room. Oh, Khaled has a question.
Yeah.
Go ahead.
No, it's not a question. I just want to thank you also, Michelle, for moderating this session. Thank you, Mohamed, for this session. I think we're growing stronger and stronger, and I think there are more things that are coming. So I just wanted to underline that, and we will not rule out a possibility of a global conference that we will do here in Africa on pharmacogenomics. We're moving towards that. So keep connected. You will hear more things as we move forward. So I just want to thank everyone who has attended, and yeah, back to you, Michelle, to close the session. Thank you so much.
Thank you.
And I think we want to hear from the community if there's anyone out there you think we should be hearing about, or if they're a good speaker, if they have something to share that's really useful. Please share those ideas. If there's useful resources out there, please share those ideas. This is a monthly meeting, so we look forward to engaging you further. But I think that I will close there. Thank you so much.
Thank you so much. Thanks, Michelle. Thank you, Scarlett. And thanks for the attendees.
Yep.
Okay.
We look forward to seeing everyone again. Thank you so much.
Bye.
Well, before we close. No? Thank you. There is a comment on the chat box here. You can see it.